latest data about the long-term treatment of osteoporosis with anti-resorptives. Today's webcast is being viewed by a large audience around the globe. We have almost 450 participants registered on the Osteoporosis Medical Education Worldwide Webcast website. A small note for viewers trying to access the webcast using their corporate network: firewall permissions may interrupt optimal viewing. Today, our international medical expert is Professor Richard Eastell. Professor Eastell is Professor of Bone Metabolism, University of Sheffield, and an honorary consultant physician, metabolic bone disease to the Northern General Hospital, Sheffield, England, United Kingdom. In today's webcast, Professor Eastell will provide insights on the long-term treatment of osteoporosis with anti-resorptives. Please feel free to ask any questions to Professor Eastell by typing your questions in the chat window on your webcast screen. Without further delay, I'd like to hand over the session to Professor Eastell.
Hello and welcome to this session where we're going to be talking about the long-term safety and efficacy of bisphosphonates in the treatment of postmenopausal osteoporosis. Here is a disclaimer to show you before we get going. So what I was going to cover during this webcast was starting off with the long-term efficacy of bisphosphonate treatment of postmenopausal osteoporosis, then to move on to the issues of safety, and then to reflect with you how we can balance these two factors, efficacy and safety, in making the right decisions for our patients. I'll begin by describing what evidence we have for the long-term efficacy of bisphosphonates in osteoporosis. So on this slide I'm showing you the three bisphosphonates which have been trialed for long periods of time. And so if we begin by the middle panel here, we can see that for alendronate we have the FIT, the fracture intervention trial, or FIT, which went on for about 4 years, and this was followed by a 5-year extension referred to as the FLEX trial. Once I've talked about alendronate, I'll then go on to talking about Risedronate, and this trial is the multinational VERT trial, which began as a 3-year randomized controlled trial. Then it had an extension, and then it had an open label period, so showing 7 years of data. And then finally, I'll talk to you about zoledronic acid, beginning with the first 3 years, the core trial, then the next 3 years, extension 1, and the new data that I'm going to be showing you today, the data that was shown for the first time on Saturday, is the data from extension 2, where the zoledronic acid is used out to 9 years. So let me begin then with showing you data on alendronate. So what I'm showing here is the femoral neck bone mineral density measured over the period of the FIT trial, which was about 4 years, on the left-hand side, and on the right-hand side the bone density in these same patients who then went on to be randomized to either continuing alendronate or stopping alendronate in the FLEX study, and bone density measurements were made for a further 5 years. So what you can see then is that during the period of the FIT trial, the alendronate resulted in an increase in hip BMD of around about 4%. And then when these same patients went into the FLEX trial, those patients who were randomized to alendronate maintained that benefit, whereas those that discontinued had some bone loss. Now the important point I wanted to make from this slide is that although there was bone loss during the FLEX period, the bone density did not return to baseline. So this indicates that after a period of 4 years of alendronate, there's persistent benefit on the bone density over a period of 5 years following stopping. And this idea that bisphosphonates continue to have benefits after stopping treatment is an important idea for when we discuss later on about should we be having drug holidays. Now, I've shown you there the results from bone density. Let's look now at what happened in the same trial with the measurement of bone turnover. So here I'm showing you the changes in the bone resorption marker, the cetalopeptide of type 1 collagen, CTX, measured in the serum at baseline and then at years 3 and 4 of the FIT trial. So we can see in the left-hand panel a reduction of about 70% in bone resorption during treatment. In the flex period, if the treatment is continued, bone resorption remains suppressed, but if the treatment is stopped, there is some resolution of effect of the bone resorption, and that's what we see here. Now, of course, the critical question is what is happening to fracture rates during this time. So first of all, I'll show you the results on clinical vertebral fractures. So these are fractures which are reported during the trial as episodes of back pain confirmed by radiology to be new fractures. And we can see in the green line that the rate in patients who continued in the flex study on alendronate was lower than the rate who had stopped alendronate. And the relative risk was 0.45, meaning that the reduction in clinical vertebral fracture was 55% and was significant during the flex trial. If we then look at non-vertebral fractures, we can see here that during the flex period, there was no difference between the people who continued alendronate and the patients who stopped. So no evidence for benefit of continued treatment with alendronate over this period of time when it came to non-vertebral fractures. So let's summarize what we've seen there. In the next slide, I'm showing that from the flex study, we can see that for clinical vertebral fractures, there was a benefit in continuing onto treatment for up to 9 years. Whereas for the morphometric vertebral fractures, which are the ones diagnosed by X-ray, there didn't seem to be much of an effect. And for the clinical fractures, by any classification, there didn't seem to be much of a benefit in continuing treatment. So let's move on now to alendronate. So here I'm showing the multinational VERT trial, and now we're looking at bone density of the lumbar spine. So if we look first of all at the blue line with the blue squares, we can see that when Risedronate was administered 5 milligrams a day for 7 years, there was a progressive increase in spine BMD, such that by the end of the 7 years, there was an increase of about 12%. In the placebo group, there was little change over the first 5 years when the patients just received calcium and vitamin D. But at the 5-year time point, the patients were all begun on open label Risedronate, and you can see that as a consequence there's an increase in bone mineral density during this open label period. If we look at the same study from the point of view of bone resorption, then we published this recently, that if we again look at the blue line with the blue triangles, this shows you the patients who received Risedronate from the beginning. And so we see the suppression of about 60% in bone resorption during the 3 years of the core study. Also during the 2 years of the extension study, we had source suppression. And then also during the 2 years of the open label. So for 7 years, these patients received Risedronate and their bone resorption was suppressed by about 60%. However, within 6 months of stopping the Risedronate, the bone resorption returned to the kind of levels we had seen in the placebo group, indicating a rapid offset of effect with this bisphosphonate. If we look at the control group, We can see in the grey line how the bone resorption decreased. And of course, this is because we're not giving just a placebo, we're giving calcium and vitamin D. And these treatments actually do decrease bone resorption. And so that's why we're seeing a reduction of about 20% or so. And this is present over the first of the core period and also during the extension period. Then, in the 5 to 7 year time point, when the patients are given an open label Risedronate, we can see how the decrease occurs in bone resorption marker. And then after 7 years, when this treatment is stopped, there's a rapid resolution of the NTX back to the baseline level. So whether the patients received 7 years of Risedronate or 2 years of Risedronate, they had a rapid offset of effect. So it's likely that Risedronate differs from alendronate in the rate of resolution of effect. What happened to fractures? Well, this shows the fracture rate during the VERT multinational trial. And we can see that during the first 3 years, the core study, there was a reduction in the vertebral fracture rate. That was similar also during the extension period. And then in the open label period, where everybody received Risedronate, the rates were similar to the active treatment periods from the preceding 6 years. So it would seem as though when the patients are taking Risedronate, then the reduction in fracture risk at the spine is persistent. But we have to be careful in the interpretation of these studies because during the later periods we're down to quite small numbers, and study numbers of 81 and 83 are really too low to be making confident statements about vertebral fracture risk. So much for the oral bisphosphonates. Let's move now to zoledronic acid, and I'll begin by showing you the design of this study so that the terminology makes sense. So the design of the study, you can see along the x-axis time, and I'd like you to note that actually this is not linear, that we can go from 0 to 3 in the core study, and then 3 to 6 in the extension 1, and then 6 to 9 in the extension 2. And so the period during the extension 2 has been exploded just to show you the more detail that happened during this time, as this is the new part of the study. So after the core period, where patients were randomized to zoledronic acid and placebo, the patients who'd been given placebo were then switched to zoledronic acid, and that's the P3Z3 trial. I'm not going to say anything about that trial today because it's not relevant to our discussion. What I will do is I'll tell you about what happened during the of the zoledronic acid patients to either continue on zoledronic acid, the so-called Z6 trial, compared to the Z3P3, the patients who received placebo during the second 3 years. And that is the extension 1 study. And then, when I tell you about the extension 2 study, that'll be the patients who had received 6 years of zoledronic acid and then randomized to a further 3 years, the Z9 group, or who then were randomized to placebo, the Z6P3 group. So that's the design of the study. I'm just going to use one slide to illustrate the effects of zoledronic acid on fracture risk during the core trial. And this is shown here. So you'll recall that this is a study of 7,736 women with osteoporosis who were randomized to receiving zoledronic acid 5 milligrams annually or placebo. It was a multinational study and took place in 23 countries around the world and was completed in 2006. In this table, we summarize the effects on vertebral fracture, which was reduced by 70%, hip fracture, which was reduced by 41%, and non-vertebral fracture that was reduced by 25%. All of these effects were highly significant statistically. As a consequence of this trial, the treatment was registered for post-menopausal osteoporosis in many countries around the world. Now, we're now going to move to the extension study. So in this extension study, we took the patients who were randomized to zoledronic acid during the core study, and then they were further randomized to receive further zoledronic acid, the Z6 study, which there were 617 people, or randomized to receive placebo, Z3P3, of which there were 616 people. So let's see what happened to these people. So what I'm showing here is the bone density at the femoral neck over the 6-year period of the core trial and extension 1. So if we follow the orange line, these were the patients who received 6 zoledronic acid infusions. And we can see there the increase in the femoral neck BMD. Contrast that with the patients who received 3 injections of zoledronic acid followed by 3 injections of placebo. They had a small decline in the bone density of the femoral neck, and the difference between the two groups was 1.4%. Now, of course, that's not a very big decrease, it's quite small, and it again points to the fact that with zoledronic acid, we're having persistent benefit after we stop the drug. So what's happening with bone turnover? So in this trial, we use as our measure of bone turnover the procollagen type 1 N-propeptide, which is a measure of bone formation. Now, it might seem a paradox to use a bone formation when we're monitoring the effect of an anti-resorptive therapy. But because of coupling, the bone formation markers decrease in parallel with bone resorption markers and almost decrease to the same extent. And because in this clinical trial we had multiple countries involved, it made sense to use a marker that was robust and could be mailed from one country to another without deterioration of the sample. So that's why we have P1MP. And you can see that during the first year we had a substantial decrease in P1MP of about 60% during the core study, and it remained low during the 3 years. And then when we continued on the zoledronic acid with the orange line, then we had continued decrease of the P1MP marker. In contrast to that, there's a small increase after the first 18 months of the placebo during this extension trial. But then at the end of this period, things are the same for both treatments. And this just attests to the continued effect of zoledronic acid on bone markers for at least 3 years after stopping. So what happened to vertebral fractures? So here we can see the results of morphometric and clinical vertebral fractures. And what happened was that in the group that received 6 years of zoledronic acid, the rate of having morphometric fractures was about half that of the group that was randomized to placebo during the extension phase. So there was a benefit of giving the 6 injections compared to not giving them. This wasn't seen for clinical vertebral fractures, but then they are less common events than morphometric fractures. Nor was it seen for non-vertebral fractures. And so the benefit again seems to be with vertebral fractures when we continue with the treatment rather than with non-vertebral fractures. So if I can summarize this first extension, that from safety point of view, there were no changes from what was seen in the core trial. From the bone mineral density point of view, there was more loss in the group that received placebo than received 6 injections of the zoledronic acid. And for fractures, we did see a lower vertebral fracture rate, but not a lower non-vertebral fracture rate. So our conclusion from this was that those women who had the highest risk of vertebral fracture should continue for 6 years of zoledronic acid treatment, whereas those who don't have vertebral fracture high risk can discontinue. And yet they still maintain lots of the benefits. So now we have the new data, and I want to take my time going through this with you because you're probably seeing this for the first time. And so the whole point of this one was to assess the efficacy and safety of zoledronic acid over 9 annual infusions. And so in this part of the trial, we have a 3-year randomized double-blind controlled extension, and the average age of the patients going into this is 78 years. All of the patients had previously received 6 years, 6 injections of zoledronic acid, and they were then randomized to a further 3 years or 3 years of placebo. And in this part of the trial, the primary endpoint was total hip bone mineral density. And the reason why we took that one is that we're now dealing with not very large numbers, so we couldn't have fracture as an endpoint. And secondly, the total hip tends to be a more precise measurement than the femoral neck, so that we wanted to make sure if there was any effect, that we could find it. We did have a secondary endpoint: femoral neck bone density, fractures, bone turnover markers, and safety. And I'll show you all of these results. So this is the design I showed you a few minutes ago, just pointing out that the 616 women who've been in the Z6 were eligible to go into the extension, and as a matter of fact, 95 went into the Z9 and 95 into the Z6P3. And these are the results I'm going to show you now. And you can see how they had their infusions at baseline, 1 year and 2 years. And the nomenclature, as I said before, is that by Z9 we mean those people who had 9 injections of zoledronic acid over 9 years, whereas by Z6P3 we mean those patients who were randomized to placebo, and so they got 6 injections of zoledronic acid followed by 3 years of placebo. So this shows what happened to those patients during the extension 2 period. So 95 were allocated to each group, as I just mentioned, and then 74 completed the 3 years, and 77 in the placebo group. So these are the characteristics of the patients entering this extension 2 period. So the average age, as I said already, is 78 years. And you can see that there are a substantial number of people over the age of 80, about 30% or so. Most of the people in the trial are Caucasian, about 85%. And the average femoral neck T-score is minus 2.4 at entry. More than 50% of patients had either 1 or more vertebral fractures. So I'm showing here on the right the time course over the period of 9 years of total hip bone mineral density. So the orange line shows those patients who received 9 infusions of zoledronic acid. So you can see how the bone density increased between 5 and 6% over this period of time. And over the period of the extension 2, the bone density was pretty stable. If you look at the group that received 6 years of zoledronic acid and then 3 years of placebo, you can see their bone density is a little bit lower. And to test whether there's a difference between these two, if I ask you to look at the panel on the left and also point out to you that this is percentage change, but it's actually a percentage decrease. So you can see how the Z9 group had minus 0.5 on average, which means a decrease of 0.5%. Whereas the Z6P3 had minus 1.3, which is a decrease of minus 1.3. And although there's about a 0.8% difference between those two numbers, it wasn't statistically significant. Let's look at the femoral neck bone mineral density. So here I'm showing the femoral neck bone density in the same format. So again, with the orange line, you can see the gradual build over the 9 years up to an increase of about 6%. And over the period of extension, somewhat stable bone density, whereas the Z6B3 was somewhat low. But this was not significantly different. What was happening to bone turnover markers? Well, what I'm showing here is that in the upper panel, I'm showing you the P1MP, the bone formation marker again, for consistency. But in the lower panel, I'm showing you the bone resorption marker, serum CTX. If we begin with the top panel, and look at the orange line, the patients who received zoledronic acid for 9 years, we can see the suppression during the core period to the value that's at the low limit of the reference range for healthy young women. We see the suppression during the extension 1 period as they receive more zoledronic acid, and then continuous suppression out into the extension phase. Notice that with the orange line that there is some resolution of effect over the 9 years, and so we might have thought that if we're giving injection every year for 9 years, there might be a progressive decrease in bone turnover, but actually there's a slight increase as time goes by. We don't know the reason for that. If we look at the blue line, we can see the same effect over the core period and extension 1 period of this zoledronic acid. And during the extension period, there is very little resolution of effect. The results almost identical at the end of the 9-year period. Again, illustrating this important point that after 6 years of zoledronic acid, the benefit maintains for a further 3 years at least in terms of the suppression of bone turnover. Let's look at the bottom panel now, the CTX. So we see, if we look at the orange line, the suppression in bone resorption to the low limit of the reference range for young women. Suppression of bone resorption over the next 6 to 9 years, and we can contrast that with the group which received placebo in the last 3 years, which again is rather similar bone turnover. So after stopping the zoledronic acid, the resorption remains suppressed for a further 3 years, and again we see that there's some resolution of effect over the 9-year period. So if we're seeing consistent benefit, what would happen to fractures? So here I'm showing you the vertebral fracture data on the left and the clinical fracture data on the right. And of course, we're now dealing with very small numbers. So as we see on the left, the Z9 group, 3 patients had a new vertebral fracture, and with the placebo group, 5 patients. So very small numbers. There appears to be an apparent reduction of 40%, but of course this is not significant because the numbers are too small. If we look on the right at the all clinical fractures, no significant difference. 10 in the Z9 group and 9 in the Z6P3 group. If we put those data together with the fracture data throughout the whole of the Horizon trial, I can show you in the first core period, we see this reduction in vertebral fractures of 70%. Even during the extension phase, we have a reduction of 49%. But although there's a 40% reduction during this extension 2 period, this did not reach significance, although it's not the same fractures in the active group. It's not what we saw during the preceding periods. Now, of course, one of the critical reasons for conducting this very long study is to know about safety. And particularly, we're interested in bone safety, whether there are any atypical fractures of the femur, whether there's any osteonecrosis of the jaw. And there wasn't. When we look at adverse events and serious adverse events, these were similar between the 2 groups. There was a slight imbalance in death, with just 1 in the Z9 group and 5 in the Z6P3 group. And atrial fibrillation was equal in both groups. If we look at renal function, we can look at the renal function in a couple of ways. We can see whether there's an increase in serum creatinine or a decrease in creatinine clearance in those patients with CKD. And we see that there's balance between the 2 groups. Also, we can look at urine protein, and again, no real excess there either. So no harm in relation to kidney function. So as we summarise the adverse events, then there was no difference in adverse events or serious adverse events. I mentioned the issue about slight imbalance in the death rate. No issues in relation to renal safety. 1 serious adverse event of atrial fibrillation, and no events of atypical fracture or osteonecrosis of the jaw. Of course, when you carry out this kind of extension study, there are significant limitations. So the sample size was small, only 190, so that means that the power to detect differences is low, especially when we're looking at clinical endpoints such as vertebral fractures or other fractures and the adverse events. And of course there's no true placebo group because the control group had received 6 years previously with zoledronic acid. So let's summarise what we've learnt. That over this final 3-year period, there is a slightly greater decline in the hip bone density in the Z6P3 group, but it wasn't significantly different for the Z9 group. There's no difference in fracture incidence because there's low numbers, and there was no new safety concerns. So our conclusion on looking at this data is that there really is no evidence of continuing zoledronic acid beyond 6 years based on this study. And because there's concern about the long-term use of bisphosphonates, which I'll come across in just a moment, then we would suggest that zoledronic acid should be discontinued after 6 years of annual infusions, or for some patients 3 years, and they will retain many of the benefits that they've received from this drug. So I've discussed with you now the trials that relate to long-term efficacy, and I want to move on to this issue of safety of long-term treatment with bisphosphonates. So in this section, I'll begin by just reminding you of the benefits of treatment, because of course you need to take this into account when interpreting the risks. In discussing the risks, I will make use of 2 recent reviews that are shown here on the right from Kozler and McClung, and I'll particularly discuss these items I've highlighted in black, namely the atypical femur fracture, the osteonecrosis of the jaw, atrial fibrillation, and esophageal cancer. There have been reports of esophagitis after the oral bisphosphonates, and we try and minimise this by giving the treatment with a full glass of water and then asking the patient not to lie down. We have to be cautious in chronic kidney disease not to aggravate the situation, and so we avoid using bisphosphonates with chronic kidney disease. And the side effect of iritis occurs sporadically and in an unpredictable way. And I'll finish off by saying how we might minimise these safety concerns. I must remind you that bisphosphonates really are widely used. In the USA alone, in 2008, 4 million women were prescribed oral bisphosphonates. And this contrasts with the relatively small number of people in clinical trials. The clinical trials only included about 50,000 women for up to 3 years for the major part of the trial. And so it's quite possible that when we have long-term use, and these patients are used, and these drugs are used in patients with coexistent diseases, that we might identify rare adverse events. And that's what has happened. And we see this often as adverse publicity. But this is an example from the New York Times, alerting us to the Food and Drug Administration being wary of long-term treatment with bisphosphonates because of the risk of atypical femur fracture. We'll be examining that evidence in just a moment. But I'm sure that as doctors you come across this adverse publicity all the time. Just to remind you that there are some positive aspects to the use of bisphosphonates which make them very valuable. Here in this review by Kozler, we can see on the left the reduction in vertebral fracture risk, and on the right the reduction in hip fracture risk with 4 of the licensed bisphosphonates. And we can see that the reduction in vertebral fracture risk is between 40 and 70%, a sizable benefit, and the reduction in hip fracture risk between 40 and 50% with most of the drugs. So these are really important benefits for our patients with osteoporosis. There are also some benefits which have been quite a surprise. In one clinical trial there was decreased mortality, which was reported when we gave zoledronic acid to patients with hip fracture. As I'm showing here on the right-hand side, we can see that over the period of the 3-year trial, patients who received zoledronic acid had less likelihood of dying compared to those who didn't. This observation has been supported by meta-analyses of clinical trials of patient receiving and a population-based study of patients taking osteoporosis drugs. So there may be some truth in this observation. And it can't entirely be explained by the reduction in fracture risk. Of course, some fractures are associated with significant mortality, but this doesn't explain the reduction in mortality with these drugs. We know that there's a reduction in colon cancer, particularly with the oral bisphosphonates, and there may be impacts on the aging process by bisphosphonates that we need to learn more about. So let's examine the first of these suspected adverse events, namely atypical femur fracture. So here, in these radiographs, I'm showing you the kind of appearance we see in what is known as atypical femur fracture. These fractures occur below the lesser trochanter and above the metaphyseal flare of the femur. In appearance, as we can see in the first one, that they're transverse in nature or short oblique. They occur as a result of minimal trauma, and quite often we can see a medial spike, as we see in the second of these radiographs, and there is no comminution. Now, it's critical that we have a very clear case definition, and the ASBMR, the American Society of Bone and Mineral Research, has worked hard on providing us with such a case definition. The task force first reported on this a few years ago, and now we've just had published the second task force report, and that's what I'm showing you here. And where this report's different from the first task force report, I show this in the bold text. So they require that there are 4 of the 5 major features present in order for a patient to be considered to have atypical femur fracture. Namely, that the fracture has to be a result of minimal trauma. Secondly, the fracture originates in the lateral cortex. Thirdly, that when there's a complete fracture, there's quite often a medial spike. Fourthly, that there's no comminution or only minimal comminution. And fifthly, that there's a local periosteal or endosteal reaction of the lateral cortex on the fracture site, something that's referred to as beaking. So these are the key major features that are required to define atypical fracture. And at the bottom you'll see how it says that you must exclude patients with, particularly with periprosthetic fractures or pathological fractures. And I've seen commonly people making a mistake of including these type of fractures among atypical fractures. And you'll see in a moment, when it comes to all subtrochanteric and shaft fractures, only 10% of them meet these criteria. At a clinical level, what is it you see? Well, these are essentially stress fractures or insufficiency fractures. And so in 75% of cases, we find that patients have prodromal pain. And this might be for several months before the fracture becomes apparent. Quite often, up to half of the time, the fracture is bilateral. So if you see a patient yourself, you must always remember to look at the other femur to make sure there isn't a fracture there. And there can be delayed healing in about 25% of cases. These fractures, like all stress fractures, are more likely in patients who take glucocorticoids, and also proton pump use is a risk factor. So as I mentioned a moment ago, that atypical fractures make up about 10% of all subtrochanteric fractures. And these fractures are more likely with increased duration of bisphosphonate use. Now, there have been a number of publications of this data, and this I'm showing you here that pulls all of this together. And so you'll be familiar with meta-analyses that in the middle we have a vertical bar saying 1, which indicates no risk. And we can see that most of the estimates are to the right of this, in other words, with increased risk. The studies are listed according to whether they're case control studies or cohort studies, and the case control studies appear to show a greater association than with the cohort studies, but overall the association appeared to be about a risk of 1.7, so about a 70% increase in risk of these fractures. If we look at these same meta-analyses ordered in a different way, so that we divide the studies into those that had no X-ray confirmation, which was most of them, or they did have X-ray confirmation, or they had X-ray confirmation and they used the ASBMR criteria from the first task force report. You can see that if we focus on those with the ASBMR criteria, there are two studies, one showing a risk ratio of 2.1 and one showing a risk ratio of 69. So you can see that there's quite a lot of diversity in the results from these studies. The overall estimate is a risk ratio of about 2.4 from this study. Now, it's often thought that the cause if there is a cause of these atypical fractures, is suppression, long-term severe suppression of bone turnover. Is there any evidence for this? So I went through the literature to try and find patients who had been measured around about the time of their atypical fracture, and I was able to find 8 measurements of the bone resorption marker NTX, but only 3 of these were made before the atypical fracture, and the results weren't particularly low. Shown here a shaded area, and they're not particularly low. And the same is true for studies of bone biopsy. Bone biopsy doesn't show bone turnover any lower than what's found in patients who typically take bisphosphonates. So we've not been able to prove yet that it's oversuppression of bone turnover that's the cause of this problem. This is a recent study looking at this question of what is the duration association with bisphosphonates. And so we have duration on the x-axis and risk of atypical fracture on the y-axis, and it seemed to be that in the 8th and 9th year that we were seeing the increase in the risk of this. And so it might be that after long-term treatment the problem is more severe than during short-term treatment. Now we need to put this in context. If we see a population, and in this population, let's say there's 1,000 hip fractures, then we've seen that with the bisphosphonates we should be able to reduce the number of hip fractures by 400, because the benefit of bisphosphonates is to reduce hip fracture risk by 40%. How does this compare with the number of atypical fractures we might expect from these epidemiological studies? Well, in one study, the study of Schulcher, that was published a couple of years ago in the New England Journal, they went and they identified patients with subtrochanteric or femoral shaft fractures, found 110 that were coded in this way, but then when they actually more carefully looked to see whether the coding was wrong, they only had 25 cases, and then when they looked at the appearance on the X-ray, they only ended up with 5 atypical femur fractures. So what this would mean would be that we're preventing 400 hip fractures and possibly causing 5 atypical femur fractures. So a ratio of about 100 to 1. So of course, whenever we hear about an association between one thing and another in medicine, we need to ask the question, is the association causative? This is critical, and this has been addressed by epidemiologists for many years. I'm showing you here the criteria of Austin Bradford Hill from about 50 years ago, and he made the point that if you're going to impute that there's causation, then you have to have a strong association, that the results have to be consistent, that there's a dose response, and that it's plausible biologically. So there is some association. CCP has a ratio of about 2, not very strong. There is not consistency with results. We saw just how variable the results were. We don't have a dose response because we just use one dose of the different bisphosphonates. And there may be biological plausibility of oversuppression, but it's not very well proven. So we do have to be cautious in running to the conclusion that these fractures are the consequence of the bisphosphonate, and we have to remember that we do see these fractures in patients who never received a bisphosphonate. let's move on now to osteonecrosis of the jaw. So again, we have to have a case definition, and so you can see from the photograph on the right that in this case we're seeing after tooth extraction, bone being exposed, and it's not healing after a period of 8 weeks. And this is how we define osteonecrosis of the jaw, and also there should be no radiation therapy to the craniofacial region. So that's the definition. So when that definition has been applied, what is the risk? Well, the risk seems to be mostly in the setting of malignant bone disease, where of course bisphosphonates are used about 10 times the dose of what they use in osteoporosis. And when we look at diseases like multiple myeloma, we can see rates of up to 10 out of 100 patients. This contrasts with non-malignant conditions like osteoporosis, where the rate is somewhere between 1 in 1,000 and 1 in 300,000. So, from my own personal experience, I've never seen a case of osteonecrosis of the jaw from the osteoporosis doses, but although I have seen quite a few cases of atypical femur fracture. So, the association with osteoporosis is very weak. Of course, we need to know about the risk factors, and so if there's an extraction, a tooth extraction, this can be a trigger for developing ONJ. About 97% of the reported cases of ONJ have been in the setting of intravenous bisphosphonates for malignant bone disease. Glucocorticoids and chemotherapy are risk factors, as are coexistent diseases like diabetes and alcohol excess. So let's move on now to atrial fibrillation. So, in the Horizon PFT trial, we made the strange observation that serious adverse events from atrial fibrillation were higher in the zoledronic acid group compared to the placebo group, 1.3% compared to 0.5%. We then went to look at the other clinical trials using zoledronic acid, and in these there was no association. So we were a bit puzzled by this, especially when we spoke to cardiology colleagues where no mechanisms could be identified. And so there was a review of all the clinical trials of bisphosphonates. The only other clinical trial that came up with an association were the clinical trials of pimidronate. So it may be that intravenous bisphosphonates, rather than oral bisphosphonates, might be linked to this adverse event. And so care might need to be taken in the setting of patients at risk of atrial tachyarrhythmias. So the last topic I'm going to discuss is esophageal cancer. I mentioned that esophagitis was a complication of oral bisphosphonates. If there was chronic irritation of the esophagus, it's possible that after many years this could lead to esophageal cancer. And so we read a report here in the New England Journal of Medicine 4 years ago from the Food and Drug Administration, and they reported they'd seen 23 cases of esophageal cancer, and that there were 31 cases from Europe and Japan. Now, of course, there's no mention here of the background rate of esophageal cancer, so it's critical to do research studies to find out whether the rate is excess or not. And this has been done, and these reports have been summarized in this meta-analysis from Sun. And you can see that there were 4 studies in the upper panel and 3 in the lower panel. The net observation is that there is no excess of risk of esophageal cancer. The overall estimates show no difference from 1. And so the current feeling is that esophageal cancer is not increased in patients taking oral bisphosphonates. So I've now reviewed with you the efficacy and the safety, and I want now to get down to the practical question, in whom is it safe to continue bisphosphonate therapies? So we know that for a period of 3 to 5 years, the bisphosphonates clearly prevent fractures and it's likely that the benefits outweigh the risks. The question is, how do we choose patients who can continue the treatment after the 3 to 5 year period, and which patients should have a drug holiday? I'll just remind you of 2 key points about the benefits that can be obtained by continuing treatment beyond 3 to 5 years. So in the FLEX study, we saw this reduction in clinical vertebral fractures by continuing the therapy. And in the Horizon Extension 1 study, we saw this benefit on morphometric clinical fractures by continuing the therapy a further 3 years. So the message that's coming across is that perhaps clinical vertebral fractures can be prevented by an extension of treatment. So when we look for the common themes in these long-term extension studies, based on the bone density, both the FLEX and the Horizon extensions show that long-term continuation retains the BMD gains, but there is modest bone density loss if we stop treatment. From the fracture results from these 2 trials, then there's consistent evidence that the continuation of therapy lowers the risk of vertebral fracture, but no evidence that it reduces the risk of non-vertebral fracture, although we do have to be careful because the confidence intervals are rather wide. So in terms of which patients should be continued on treatment, because there's a primary benefit seems to be on those patients with vertebral fractures, it's logical to identify patients at high risk of vertebral fracture. And so when it comes to high risk of vertebral fracture, usually we mean people with low BMD or patients with prevalent vertebral fractures. So this was discussed last year in an article in the New England Journal of Medicine by Dr. Black. And so he divided patients from the FLEX study into those with no prevalent vertebral fracture when they entered the FLEX trial, and those with prevalent vertebral fracture as the end of the FLEX trial. And he used the metric of number needed to treat. How many patients do you need to treat for those remaining years with the drug to prevent a vertebral fracture? And for the patients with no prevalent fracture, the T-score of less than minus 2.5 identified patients where you'd have to treat 24 to prevent a fracture. So this would be a reasonable number to take to treat 24 people to prevent one vertebral fracture. And similarly, for patients with a prevalent vertebral fracture who at the start of FLEX, if the T-score was either less than minus 2.5 or less than minus 2, then the number needed to treat of 17 is a very respectable number by which to choose to use this treatment for a further few years. So when we do this kind of analysis, then we do have to be cautious because there are not very many factors to make definitive conclusions. But it's unlikely we're going to get more information, so we have to make our decisions based on the evidence available. We'll hope to see efficacy on vertebral fractures and balance the benefits and risks. And we do need to know more about long-term adverse effects to be sure about these kind of decisions. So in terms of continuing alendronic acid or alendronate beyond 5 years, what we currently propose is that many women can be discontinued after 5 years of treatment. It's only those women who are at highest risk of vertebral fractures, namely those who have a femoral neck T-score of less than minus 2.5 or an existing vertebral fracture and a T-score of minus 2. And how should these rules apply to zoledronic acid? Again, many women can stop after 3 years of zoledronic acid. But those women who are at highest risk of vertebral fracture will most likely benefit from continuation of therapy. And so if the hip T-score is below minus 2.5, if there is an existing vertebral fracture, we also observed if there was an incident fracture of any kind during the period of treatment with zoledronic acid for 3 years, and these people are more likely to benefit from further treatment for 3 years. And then all patients, as they get to 6 years, can stop the therapy. And they'll continue to have benefit for at least 3 years, and so we can have a drug holiday for that time. What about other bisphosphonates? So I mentioned earlier on that the data for Risedronate and ALENDRONATE was limited, and that although it seems as though that we can continue with ALENDRONATE and zoledronic acid, because there's continued benefit after stopping, but that might not be true for Risedronate. It seems like there's faster loss of effect after stopping treatment, so we have to be careful about what we recommend, and we may not recommend drug holidays for these drugs. We can't assume that after discontinuation there's continued benefits. So I'd like now to summarise my presentation, balancing up efficacy against safety. So during the first 3 to 4 years of treatment, then, as shown by the blue arrow, the benefits on hip fracture, non-vertebral and spine fracture is great, and the risks are small. So for most patients, the benefit is exceeding the risk. Beyond 3 to 4 years, there are still some benefits, particularly in relation to vertebral fracture, but the risks start to increase. And so we're therefore more careful in who we select to go into treatment during this period. And we use the Bernesity and vertebral fracture criteria. Once we could talk about going beyond 6 years for zoledronic acid or 10 years for ALENDRONATE, then we really are into a difficult period where the benefits are just not proven, and it does appear as though there may be risks of long-term treatment. And so we should be a lot more cautious about using these drugs beyond those time periods. So now I'm summing up what I think, which is that 6 years of annual infusions with the zoledronic acid preserve the bone mass in the trial that I've shown you, and provides continuous fracture protection. That the new data which has been generated by the second extension study underpin the safety profile of zoledronic acid. The decision on whether or not to give bisphosphonate treatment in the long term should be taken on an individualized basis. And this is consistent with the ASBMR task force report, which I give a reference to at the bottom of the page. And it may be beneficial in some patients, particularly those with high vertebral fracture risk, to treat with zoledronic acid beyond 3 years. And so I've tried to make the point that the T-score of less than -2.5, or a vertebral fracture, or an incident fracture, all put a patient at risk of vertebral fracture, and these patients are most suited to continuing treatment with zoledronic acid. So I've tried to give you my opinion of the data, of risk and benefit, and how we might manage patients. And so thank you for your questions. So thank you for your attention, and I'll be happy to answer any questions.
Thank you, Professor Eastel, for that insight. We would encourage participants to please type in questions